the new concepts in ventilation. And we'll review the existing patient-triggered mode because we need to know that why we want to use another mode. And the most important part of the patient ventilator synchrony is to be highlighted. And how does this neural control ventilation works? What is the principle? How do we set it up? And what is the clinical evidence to support us our use? And having said that, NAVA is actually invasive and non-invasive both. So that's the thing which we need to know. So even when we are through the endotracheal tube also, you can actually have a NAVA, and we can have a non-invasive NAVA as well. So if we go back to our history, if we go back to our history, 1950, when the NAVA had not yet come into the picture, we had just started with the ventilation as such. And what we started was a controlled mode of ventilation. And we understood that we had actually caused much damages to the baby by controlled ventilation, because there was a lot of asynchrony. Baby was breathing, his inspiration was separate, his expiration was separate, the rates were separate, and the ventilator was giving its own breaths. And so came the role of controlling that part by using more and more of sedation and more of paralytic agents, which would actually cause more harm and would prolong the ventilation for these babies. And then we thought, okay, let's start assisting these breaths, so that let's start synchronizing the breaths with the baby. And then came SIMV. So in SIMV, we were just trying to synchronize a certain number of breaths, like 30, 40, whatever we were keeping on the setting. And rest of the breaths were not getting synchronized. And that too, those 40 breaths would be synchronized only when it is going to, the baby is going to trigger at that particular time, which we have given for the trigger. Otherwise, if it's not triggering at that time, that breath is also not going to be synchronized. So, so though it is called synchronized intermittent mandatory ventilation, it was intermittent synchronization only. And hence we tried to synchronize more, and we tried to synchronize all the breaths of the baby. So we came to the assist ventilation, control of ventilation, and which is like pressure supported and the volume supported. And then we also added the pressure support ventilation into, which is a different modality altogether. Then we thought that, oh, we are giving either pressure or we are giving volume, then we might lead to a volume trauma when we are using only pressure support, or volume support, then we might cause the pressure trauma. So we try to combine those modes by either going for a volume guarantee ventilation or TTV, that is targeting the tidal volume ventilation in SLE and the dragger, that's the mode, or combining them by APRV to have more better synchronized as well as control kind of a ventilation which is gentler to the baby as the baby's requirement. And then we went to a complex algorithms like proportional positive support or a positive assist ventilation. So these are the different modes. It's a lecture by itself. Different modes have their own lectures, but I just wanted to give you overview how we developed further and what we gained by developing further. And in 2007 came NAVA. Okay, so when we use the conventional mode of ventilation, they were time cycled, pressure limited ventilators. And then we try, as I said, we try to target the tidal volume by either TTV mode or a volume guarantee mode, so that we don't, when the baby's compliance starts improving and we continue to give the same pressure, we might cause volume trauma. So to take care of that. And then there is a pressure support ventilation when the baby is trying to take care of, control his own breaths and just needs a little bit of pressure support. And that is supposedly the most comfortable for the baby mode of ventilation. And as I said, proportional amplification methods were included to amplify depending on the requirement of the baby, the pressures are to be amplified. So having said that, even when we did our maximum ways to have a kind of a smooth synchronization and volume taking care of, still the technology limited to detect the signal from the patient, because we are trying to trigger, taking a trigger or signal from the patient, which different ventilator modes would take from the pressure or flow and plethysmography. There may be a limitation to detect these signals. Also, we are putting an endotracheal tube, which will additionally give a resistance to the these flows. And also the ventilator circuit itself has a resistance. Also, because we are using for our babies uncuffed endotracheal tubes, so there might be a possibility of air leaks. So that means that still we might have a asynchrony at the trigger level, at the flow level, at the plateau level, and at the end of inspiration and expiration level. So there may still be asynchrony. And how does it happen? Like phase of an assisted ventilation breaths depends on that, and the type of patient ventilator dysynchrony. Now, as I said, in the trigger, there might be a problem. So patient initiates a breath, but still you may have a trigger in synchrony because of the fact that some of the babies may have ineffective efforts. They may have failure to trigger because they are not triggering at that point where you ask them to trigger. Or there could be a double triggering because you have kept the inspiratory time of the ventilator less than the neural inspiratory time. Or there could be an auto triggering because of the water in the circuit, or it could be due to the hiccups, or it could be due to the change in the flow due to any other reasons. So you may have a problem with the trigger asynchrony. And then, as I said, the flow asynchrony may happen because the patient demands airflow from the ventilator, which is not as it is requiring. And so there will be coming a flow asynchrony. And then the end of inspiration and breath triggering could be a problem because the termination asynchrony can happen when the ventilator is ending the breath either prematurely or it is delaying, because this can happen because you are the one who is keeping the inspiratory time. And end of expiration may have a problem, especially even when you are putting a pressure support ventilation where you say that inspiratory time is set by the baby, but the expiratory asynchrony can still happen in the pressure support ventilation because it is going to be stopping when there will be a 25% reduction in the flow, which may change with the baby. So now to overcome, to see it more visually, how this asynchrony actually is happening, because it's all the diaphragm contraction which is leading to the baby's ventilation. So supposing this is the diaphragmatic contraction which is happening, these are the ones which are happening, and you see the baby is getting pressure at this time. So the contraction started much earlier and the pressure delivered by the ventilator is quite late in all these. So this is a ventilator reaction is too late after the diaphragmatic activation has occurred. This is happening in your pressure support ventilation. The another thing which happens in that is sometimes there is a diaphragm activation happening, but the ventilator is not giving any kind of reaction. So either there is a delay or there is no reaction. So both of them are causing asynchrony to the between the baby and the ventilator. between the baby and the baby's diaphragmatic activity and the ventilator. So here the neural inspiration has been triggered by the diaphragm contraction, and this is the neural expiration. But there is a trigger delay from when the diaphragm has started to contract to when the baby is giving trigger and the ventilator is receiving the trigger. So there is a delay here. And then during the neural inspiration, the baby neural activity has stopped and actually expiration has started, but the ventilator is still continue to give the inspiration, and then the expiration starts. So we can see that these are the two portions where there is an asynchrony. Here, when trigger delay is there, so inspiration has not begun. And here, when inspiration is still going on, when the neural inspiration is not required. So these are the two asynchrony which is happening. And this is quite a lot. 53% of asynchrony has happened because of this difference. And prolonged expiratory neural time induced by the mechanical ventilator in infants, the synchronized cycle is actually 53% asynchronous, and only 47% synchronous has with the neural timing is occurring. So this is very important, and this is how you will see when you look at the if you want to look at the diaphragm contraction and the ventilator response, that there is a asynchrony here and here. Now, if you now decide to actually synchronize your ventilation with the EDI, that is electrical activity of diaphragm, what you see, this is the electrical activity of the diaphragm which is happening. And this is the time when the pressure is increased, and this is the flow. So you can see how synchronous, first of all, it is. Also, there is no wasted effort. There is no time when the diaphragm has started the activity and the pressure is not being delivered. So this is important. Another thing which is seen by the research is that when you mechanically ventilate any baby, there is a atrophy of the diaphragm which starts happening, and it will depend on how long you are ventilating these babies. So if you see, light blue is the control where there is no ventilation being given to the babies, and dark blue is the case where the baby is on ventilator. And what you can see on the y-axis, this is a fibers cross-sectional area, and there is a reduction in the slow twitch fibers in the babies who were ventilated versus the babies who were not ventilated. And also there was a reduction in the fast twitch fibers in the babies who were ventilated versus babies who were not ventilated. That means there is a rapid disuse atrophy of the diaphragm fibers in all these babies who are mechanically ventilated. And if you see it in histopathology, these are the controls where you have a nice fiber size, and in the cases the fiber size has reduced. And even the slow myosin heavy chain is smaller than in the control. The fast myosin heavy chain is also smaller, reduced in size than the controls. So this is a very, very important thing to be noted in the babies who are mechanically ventilated, whatever mode you are using. Now, why you want a neonatal ventilator synchrony to happen? We all know that if the baby is breathing out of proportion or against the ventilator, what's going to happen? It is going to increase the work of breathing of the baby. So if you are going to time the breath delivery according to the baby's breath, it is definitely going to decrease the work of the breathing, and it will improve the gas exchange. So you will have a better PO2, you will have a better CO2. And this is going to unload the respiratory muscles, and hence there will be a less muscular injury, which may be associated with controlled mechanical ventilator. Now, whenever you want to synchronize a newborn, what you want is you want to prevent any ineffective, any delayed, what we said about earlier, any double triggering, auto triggering, all these may impair lung mechanics. They may impair the gas exchange, and this in turn may cause a more use of your sedation and more use of sometimes paralytic agents, especially in the meconium aspiration syndromes, and this will prolong the duration of recovery. So synchrony is very important. Also, there is a chance of intrinsic PEEP generation due to this, and there may be a dynamic hyperinflation which may happen over a period of time. So these two are also not good for our babies. Now, supposing when we want to compare NAVA versus pressure support ventilation, especially when we are using the leaking tubes. So when you are using a leaking tube, there may happen because of the leak, there is no trigger. When there is no trigger, there is no delivery of pressure to the patient. However, in NAVA, there is nothing related to the leak, because that's not the trigger which is asking the ventilator to give the breaths. It is the EDI, that is diaphragmatic activity, which is causing the asking the ventilator to give the breaths. So there will be never a problem with the NAVA that there is no trigger and there is no ventilation being given to the baby. And hence, if you look at the babies who are on PSP with the same kind of a lung pathology and you compare with the babies who are in NAVA, you will see that PO2s are on the lower side and PCO2s are on the higher side. Vis-a-vis, PO2 is quite high and PCO2 is quite low. So this is the thing which is quite glaringly different between the two. Now, when we are using the NAVA, the major reason why we want the triggering on diaphragmatic electrical activity is, first, as we saw, with the mechanical ventilation, when diaphragm is not being used, it is causing a diaphragmatic dysfunction. So you want to avoid a diaphragmatic dysfunction. You are still not synchronous, and so you are having a increased work of breathing. So you want to, with this EDI use, you are going to reduce the work of the breathing. And the third, the most important thing is the synchrony, the match between the patient and the ventilator will improve the patient's comfort. So this is our aim when we are using the EDI. Now, how does EDI works? So the healthy brain will give a stimulus to the diaphragm to contract, that yes, you contract and the breathing would start. So if a baby or person is healthy, it is going to give a little stimulus to say that, okay, small contraction is required for the baby, for the ventilation to occur. However, if the lungs are RDS, the brain knows that you require a more contraction. So it's going to give a more stimulus to the diaphragm, and there will be a more electrical activity of the diaphragm to produce more tidal volume. And hence, you can see the EDI of a healthy lung is going to be this much smaller, whereas the EDI of the lung which is diseased is going to increase. And as the disease is going to increase further, the EDI is going to go higher. And because we need the tidal volume requirement would be the same, but you need a more support, more contraction to achieve the same kind of a tidal volume. So this is very important. So there is a neuromuscular coupling which will result in respiratory muscle, will determine the degree of respiratory output. So as we can see, if we have normal breaths, the air EDI is quite small, and so is the airway pressure, which is small, and we are getting a good tidal volume. However, if you see that the demand is increased, your EDI is increased, the pressure is going to increase to achieve that much of tidal volume. And there may be a voluntary increase in expiratory lung volume. So there may be less or higher EDI, and proportionately the pressure is going to change. So there is a change in the same cycle. You may see the EDI might be different, and hence the pressure might be different to achieve that much of tidal volume. So what is the clinical effect of the neural control? Of course, as we can see, the patient-ventilator interaction is going to improve, and the patient is the one who is assuming the full control of magnitude and timing of the mechanical support. So how much you are diseased, that much you want, and that much the ventilator is going to give you. So also it will reduce the risk of iatrogenic hyperinflation. So it will reduce the chances of your respiratory alkalosis and hemodynamic impairment because of your hyperinflation, which we saw could happen in your mechanical ventilation. And of course, it is going to produce more and more of synchrony. Baby is going to be more comfortable. The oxygenation is going to improve, and the chances of pneumothorax are going to be much lesser. So what we want that there should be a direct connection of the central nervous system to the ventilator unit. Okay, I want to breathe, and straight time the ventilator unit should start. Maybe over some more times we will be talking about it, but that thing has not happened till now. What we had initially was that there was a connection of stimulus from the chest wall and lung expansion to the ventilator unit, which was quite not okay. And so we went to that the airflow, airway pressure, or the flow or the volume has a direct connection to the ventilator unit to tell the ventilator how much pressure is required to be delivered and when to be delivered to the baby. And in NAVA, what is happening is that straight from the diaphragmatic excitation, the new technology, the ventilator knows when to give the pressure, for how long to give the pressure, and how much to give the pressure. So this is the tube which goes to the diaphragm, and actually these are the diaphragm, and here are the electrodes which will pick up the diaphragmatic activity and tell to the ventilator, this is the diaphragm, what the patient wants, so deliver this much of pressure. So this is the new technology. Now, if you see how the flow trigger worked, there was here the flow sensor, which would sense the change in the flow by knowing the change in the temperature of the gas. And so this will tell to synchronize for the initiation of breaths. So that can happen. And it responds to the patient's respiratory efforts. So advantage was the control of volume and pressure by the physician. But this is not completely synchronized. And so we are actually still the physician is actually controlling the things rather than the patient. And the patient is only controlling the initiation of breath. So when we use NAVA, we put this EDI catheter. The brain is giving the stimulus to the diaphragm. The diaphragm contracts. The catheter knows about it. It tells to the ventilator when to start the breaths and how much pressure to be delivered. And so the synchronization for initiation is there. For termination of each breath is there with the, whether you are using endotracheal tube NAVA or you are using non-invasive NAVA. And it responds to the respiratory drive. So the advantage is that you have a lower pressures given, you have a lower tidal volume, the work of breathing is lower, and you have a better blood gases with these lower pressure and tidal volume. Comfort score is much better, and you don't need much of sedation. So this is how it works. We will talk more about this in next few slides. But what I want to tell here is that there are two things. One, that there is a tonic activity during expiration when the baby is expiring, and then that is tonic EDI, which is minimum, that is 2 to 5 microvolt. And when there is a peak inspiration, there is a contraction of the diaphragm, and their EDI maximum is 5 to 15. That's the usual one. And we keep the NAVA level to tell how much pressure the ventilator should be giving to the baby. Even when we, even if we increase the NAVA level, still the tidal volume is not going to go beyond a particular level, because there is a hearing mirror reflex which will prevent the overinflation, and which is very well working during the NAVA. We'll explain more about it. So how reliable is the EDI signal? EDI signal while feeding, does the electrical activity generated by suck swallow interferes with EDI signal? Or EDI signal while burping, do the mechanical back blows create a false sense or triggering? Does it happen? Because if it happens, then it is going to be too much causing kind of issues. So this is the video is not running somehow. So this is just, it was showing that, see, this is your catheter which you have put in, and there is 100% leak which is happening. This is NAVA, that is non-invasive NAVA. And still there is a synchronous of the chest movements and the ventilator breaths. So I don't know, actually, this is not working. This is working. Oh, this is also not working. This was showing if you're feeding the baby, still there is no kind of issue with the breaths. Anyway, we'll see later if it works. Now, if you compare SIMV, pressure control, and NAVA, so if a baby is acidotic, and then you shift from SIMV or pressure control to NAVA, you will find there is a difference. That the pH, which was 7.29, has increased to 7.32, and CO2s, which were 55.9, dropped down to 49.5, and it is quite significant. However, if you want to put a baby from SIMV or pressure control to NAVA who has a normal pH and PCO2, there is not going to be much difference. So 7.39 to 7.38, not a big difference. 39.5 of PCO2 to 40.8, not a big difference. So there is no point putting those babies into NAVA. Now, these are the examples when you have put the baby from the pressure control to NAVA, how the PIP has decreased when you put on the NAVA. So these are the 4 examples. A 33-weeker, 2.260 gram baby on who was having RDS and was requiring 25 of PIP and still was not maintaining his CO2s and O2s. Baby was put on NAVA, and with a NAVA level of 2.5, you see what is happening to the pressures. The PIP has come down from 25 to 20. Another baby, 32-weeker, 2.140. Now this is BPD, and so that's why it's requiring very high pressure of 30. And hence we know that this baby is going to require a higher support. So you will keep a higher NAVA level of 5. And then what happened was that from 30, the pressure came down to 24, 23. Then another baby, 30-weeker, 1.150 RDS with a pneumothorax. A pneumothorax, you will put a lower NAVA level. And the baby requiring pressure of 20. And now the pressure requirement came down to 17 or 18. Another baby who was 3 months old, ex-28-weeker infant with pulmonary hyperplasia was on NAVA 2. From 30, the NAVA level came down, the pressure level came down to 28. So this is the beauty of NAVA. So if you compare conventional ventilation versus NAVA, this is very important that in the conventional ventilation, the patient controls using a flow trigger. So it is controlling only one thing in most of them, and that is initiation of breath. And in some of them, like in access control and in pressure support, even the rates. However, the NAVA patient controls using the neural trigger, and it controls everything like initiation of breath, inspiratory time, rate, PIC, PIP, and termination of breath. What is the ventilator control in NAVA? Only FiO2 and PEEP. Whereas in the conventional mode of ventilation, the ventilator controls the PIP, the tidal volume, inspiratory time, termination of breath, PEEP, minimum rate, and FiO2. So almost everything is controlled by the ventilator. And synchrony is only for the initiation of breath. And there might be a false triggering. So for the other breaths, there will be asynchrony. And here, synchrony is for the initiation of breath, for the size of breath, and for the termination of breath. So this is how you will, actually, when you're setting the NAVA, this is how it will look like, the screen would look like. So you will be able to see the PIP, the PEEP, the rate of the baby, the tidal volume, maximum and in the inspiration and the expiration, the minute ventilation, the EDI, peak and minimum, and the NAVA level. So this is what you will be able to see. And then you will also see the, if it is invasive one, you will see the PC above PEEP, the respiratory rate, and the PEEP. This is how the thing will look like. So how do you set a NIV in the non-invasive NAVA in a newborn? Then how the PIP is being set is, PIP will be equal to NAVA level into EDI maximum minus minimum. So peak minus minimum plus PEEP plus 2. And when in a invasive NAVA, it will be NAVA level into EDI peak minus minimum plus PEEP. Here you won't add 2. So what is this EDI? As we already talked about, that it is an instantaneous integral of the diaphragmatic electrical activity signal, which is measured in microwatt. And what is the NAVA level? Is actually it is centimeter water per microwatt, or a per arbitrary unit. It is a proportionality constant set by clinicians. So this is what we will be setting depending on what EDI you are going to see, depending on what EDI the baby is generating, to know what is the requirement of that particular baby for the pressures. So if you keep on increasing the NAVA level, as I said, there is a safety mechanism here that there will be no increase of tidal volume above a particular level because of the hearing bureau reflex, which is operative. So it will stop the output from the respiratory control center at the tidal volume, irrespective of the NAVA level. So this is very good for our safety for our babies. Now, how do you use NIV-NAVA for synchronized non-invasive ventilation? So how do you set is that you want to set a trigger, and how usually you will set a trigger level of 0.5 EDI, which means that the ventilator would respond to the trigger of when the baby is generating more than what you have put as 0.5 plus 0.3, because 0.3 is the minimum tonic activity of the diaphragm. So 0.3 plus what you have set is 0.5. So that means 0.3 plus 0.5 is 0.8. So only when the baby EDI activity is more than 0.8, that is the time when the ventilator would start delivering. the pressure. And the pressure delivered will be equal to NAVA level into EDI signal maximum minus minimum plus P plus 2. So it will start delivering, this is the EDI maximum, and this will start giving a pressure when you have kept a NAVA level of 1. And when does it stop? So it will stop when EDI signal, you see this EDI signal is going up and then it is coming down. When the EDI signal falls to 70% of its peak value, that is the time when it stops and the expiration would begin. So how the trigger occurs, I hope you understood. You kept the trigger of 0.5, but it will start triggering with 0.5 plus 0.3, which is the minimum EDI, that is 0.8. And it will continue and increase proportional to the NAVA level, what you have kept. And it will end once your EDI has dropped to 75% of its peak value when the exhalation would start. So this is how it is. And all this is being captured by the catheter which we had put. And this catheter is not MRI compatible. So don't take your baby with the NAVA to the MRI. And once you have put this catheter, usually you use it for 5 days. Now see, how do we set? Now, this is invasive NAVA, which we are setting. So you see, this is the EDI peak is 7.6. EDI minimum is 0.1. So 7.6 minus 0.1 is 7.5. The NAVA level is kept as 2. Seeing the baby's requirement. The PEEP is kept as 3. So now, oh, sorry. So now, how much would be your estimated PIP? So 2 into 7.5 plus 3. So 2 into 7.5 is how much?
15.
Yeah. plus 3. So that is almost 17, 18. So that is what the baby is getting. So this is how it is calculating. So when you have set it, this is how the EDI curve will look like. And if you see, all are getting, all are actually synchronous with your EDI curve. Your pressure, your flow, and your volume is synchronous with your EDI. So NAVA level, as I said, is actually the workload done by the ventilator. So if you are keeping the higher NAVA level, that means more work is done by the ventilator. If you are keeping the NAVA level low, that means more work is done by the patient. So usually you will start at NAVA level of 2 and you will wean depending on what EDI activity you are seeing. So normally, as we know, that EDI activity is 5 to 10. However, if your EDI activity is very high, like 15 to 30, that means your baby is actually trying, knowing that your lungs are not, his lung is not okay, and trying, the diaphragm is trying to generate more electrical activity to generate more pressure. So that means your NAVA level, you should be having higher than this. So you will increase your NAVA level 0.1, 0.2, 0.2 each time to see that the EDI level is coming to normal. But if your EDI level is too low, that means the baby doesn't require that much of pressures. So, and it doesn't require that much of support of the ventilator. And so you will start reducing the NAVA level so as to let the patient do more work. That's how you keep the NAVA level. So one time you will keep a particular NAVA level, but then you will titrate the NAVA level depending on what EDI you are seeing. And you have to give time for the EDI. Don't just react immediately. Give some time so that it settles, and then you can change your NAVA level. So NAVA trigger, usually we are setting a EDI at 0.5. And as I said, the trigger will start after 0.5 plus 0.3, that is 0.8. And we know, we should know what is breakpoint. Now, what is breakpoint? Now, what is happening here? We are increasing the NAVA level. So when we are increasing the NAVA level, what is happening? The pressure is increasing. Fine. And the tidal volume is increasing along with that. After some time, at one particular level of the NAVA level, even if you're increasing the NAVA level, see, I have increased to this, the tidal volume is not going to change. The pressure is not going to change to give that much of tidal volume. This is the break point of the NAVA level. So this is the point where you will be keeping your NAVA level. And the exhalation will start when the peak of EDI falls to 70% of the peak. We already talked about it. So you see here, this is showing that the Y-axis is showing airway pressure, and here it is showing the diaphragm electrical activity. And these are the NAVA levels. So if you see that even when you have given a NAVA gain of 1, if the electrical activity is increasing, the airway pressure is going to be increased. However, we cannot go more, because if the electrical activity is increasing, you need to increase the NAVA to give that much of pressure. So as the electrical activity is going to increase, the pressure is going to increase. As the NAVA level is going to increase, the pressure is going to increase. But even with a higher NAVA level, if your electrical activity is not much, it is not going to give more of pressures. So this is sign how the electrical activity is actually taking care of the pressure requirement by the baby. So now how do we set and how do we place the EDI catheter? Now we come to a practical point of view. So there is a retrocardiac EKG which is seen on the catheter position screen. And what we see is that there is, this is the positional screen, we'll go further. There is at the topmost, there is a wave and QRS complex, which is maximum, largest. And at the bottom, you have the smallest. And in between, you have a medium sized. And there is a color of in between is blue. So I will talk about it later, but that's how it is seen. How do you calculate the size to begin with is you actually measure from the nose to the ear and to the xiphoid. So that is nose, ear, xiphoid, necks. So this is the measurement which what you take. And then depending on whether you are putting through the nasal or through the oral, the size is going to be different. And depending on which French catheter and what size are you using, the length would be different. So if supposing you are putting a nasal insertion, the distance would be, if you're using an 8 French 100 centimeter, the next what you have measured into 0.9, that is next into 0.9 is for the nasal insertion, and next into 0.8 is for your oral insertion. So this is same, this is constant. But what you add would be different for different French catheter. So for an 8 French catheter of 100 centimeter, you will add 8 to it. And for a 6 French catheter, 50 centimeter, you will add 3.5. And for 49 centimeter, you will add 2.5. So this will be the length of insertion to begin with. Because see, you know, you need to know, you can titrate later, but what you need to start, like what NAVA level I will start, how much length I'm going to put to begin with, and then how to titrate will come next. So this is the length which you will calculate to begin with. And for oral insertion, again, if 8 French 100 centimeter, next into 0.8 plus 8. If 6 French 50 centimeter, next into 0.8 plus 3.5 and 0.8 into 2.5. So these are the lengths given. How do you calculate the length? Now, how do you decide that which baby will be using which French catheter? So this is important. So you use a 6 French 49 centimeter catheter for a baby who is 0.5 to 1.5 kg, a 6 French 50 centimeter for more than 1.5 to 2.5 kg baby, 8 French 100 centimeter for baby who is more than 2.5 kg. So this is how you decide and then you calculate. So once you have decided this French catheter I'm going to use, we will dip the catheter in the sterile water and then we start inserting up to the line, up to the mark which we have calculated. Once we have done that, we will start looking at this ECG. As I said, the topmost is the tallest and the lowermost is the smallest, and the blue is in the center. Now, if in case this blue line is only in the top, okay? So if the blue line is only on the top line, that means you have put the catheter too much in, so you will actually pull it out. If the blue line is in the bottom line, that means the catheter is not deep enough, so you will push it further. So this is how you will titrate. So first we have decided what length to use. Once we have put that much length, we have to titrate because we have to see these EKG which will come on the monitor. This comes as EDI catheter positioning, and topmost blue means you are too much in, pull it out. Lowermost blue, you are too much up, push it in. So this is how you do it. And then you start also looking at EDI range. Peak is usually 5 to 15 and minimum is 2 to 4. I hope it's clear. So now NAVA setting, how do we do? So there is a, if you see, there is a trigger and then this is a neural inspiratory, sorry. So this is the onset of the EDI when the trigger would happen, and there will be a EDI minimum, and this is the EDI peak. Okay, so and till it reduces to 70% of the peak EDI, the inspiration will continue. So from beginning of this to the time when 70% reduction in the peak EDI has happened, this is your inspiratory time. And till you begin your next trigger, that will be your expiratory time. And so this is called neural inspiratory time, and this is a neural expiratory time. So usually EDI peak will tell how much PIP is being generated, that is almost proportional to that. And it is a neural inspiratory effort and responsible for size and duration of the breath. EDI minimum is the PEEP. So below that, there will be a collapse if there is no EDI minimum. So there has to be EDI minimum to keep that PEEP. And this is a spontaneous tonic activity of the diaphragm so that there is no de-recruitment of the lung happening in expiration. And EDI trigger, as I said, is the flow trigger. So this is a minimum increase in the EDI from the previous trough that triggers the ventilator. And NAVA level, as we said, it is a conversion factor which converts the EDI signal into a proportional pressure. I hope it's clear. So as already discussed, how do you set the NAVA level? Because you need to reach to break point. That you start at level of 1, look at the EDI peak and the work of breathing. So if the EDI is constantly high, more than 15 and 20, and the patient has a lot of retractions, you need to increase the NAVA level by 0.2 to 0.5 every few minutes. And when you are increasing this NAVA level, what is happening? This EDI peak has increased, is more. So till you are increasing the NAVA, till the EDI peak is no more increasing, it's coming back to down, and your pressure is no more increasing. So that is the break point where you will keep the NAVA. So when the peak pressure no longer increases and the EDI peak starts decreasing, this is the break point where you will keep the NAVA level. So this is the baby who is on CPAP. This is the baby who is on NIPPV. So, and here is the time when you have switched the baby from this to NAVA. And initially you have kept, so you can see what's happening here, that in the CPAP, definitely there is not pressure generated. In the second, where you have put the baby on NIPPV, there is a pressure generated. So little bit of improvement in the gases, but still the pH is quite low. CO2 is quite high. And you have put the baby on NIV-NAVA here. And so from when you have put the baby on the NIPPV, it has got better to 7.14 and PCO2 of 80. But still it's not fine. So once you have put the baby on the NIV-NAVA, you can see slowly when you have kept the pressure limit as 20, still the baby actually, because it's very bad damaged lung, the pH is 7.25, but PCO2 is still 56. So when you increase the pressure limit higher, the pH has improved. So depending on how you have actually set the NAVA level to get the EDI peak of 5 to 15, it takes time. So it took around 4 hours for us to actually know exactly what limit of PIP is required by this particular baby, and which is quite high. And then your blood gas has improved, and slowly the baby requirement of the pressure would come down by itself. So this is how you will be keeping NIV-NAVA level of this baby. So how to set a EDI trigger, as we all said that, already said that we are actually setting a default trigger of 0.5. And if we keep it lower than this, it will actually result in auto triggering. What problems we were facing in the conventional mode of ventilation, here also you may start having an auto triggering. So don't go below 0.5. And when you kept 0.5, it means the trigger will happen after the diaphragm activity will reach more than 0.8, because this EDI minimum is 0.3. And the expiration starts once the EDI is 70% of the EDI peak. So, so this is when you are already, we talked about it, that there is a trigger after 0.8 and the EDI increases. And this is still here, it is the PEEP, and then the PIP is started. And once the EDI maximum has come to 70% of its peak, there will be a expiration which will start. So how do you set your NIV-NAVA? Usually you will set initial setting of 1, and maximum you can go by to 4, but don't jump to 4. You have to go slowly, 0.1 to 0.2 centimeter water per microwatt. That's how you are going to be going. But don't, when you're coming down, you should not go below 0.5. And EDI maximum is 5 to 15. For any EDI maximum, if it is going beyond 20, we have to increase the NAVA level. And if the EDI maximum is less than 5, we have to reduce the NAVA level. So usually the NAVA levels in the NIV-NAVA are lower than in the invasive NAVA. And so the usual NAVA level is 0.5 to 1 in the NIV, and in the invasive it is little higher. EDI minimum is 2 to 4, and that is telling us PEEP adjustments. If EDI minimal, so if the EDI minimum is high, constantly above 1, then you need to increase the PEEP. If the EDI minimum is too low, then means you need to decrease the PEEP. That means it's already generating PEEP and doesn't require much. So PEEP adjustment can be done using the EDI minimum, and PIP adjustment can be done, and NAVA adjustment can be done by using EDI maximum. Then the EDI trigger, as we said, you should not go beyond less than 0.5, but when the baby is improving, you can go up to 2, and you can adjust as needed. The backup pressure control above PEEP has to be kept initially 15, and maximum you can go 30 to 35, and you can go just 1 to 2 centimeter water as per NIPPV, whatever was required that time. And the rate, you will keep the backup rate, you will keep as 30, and inspiratory time in the backup, you will keep as 0.5, and trigger sensitivity 1 to 2. So the maximum pressure you can keep is 40. So when you are giving a NIV-NAVA order sheet, first of all, you will insert appropriately sized NAVA catheter. You will verify the position, how catheter you will measure, and you will put using those formulas. And then you will verify your position depending on the blue rays, which should be in the center. If it is blue only up, that means it is too much up. And so you have to shin. If it is down, then that means you are quite up, then you have to push it down the catheter. So you have to change according to where you are seeing the blue lines. Blue lines too much low, that means your catheter is too much high, you have to push it down. Blue line up, that means you are too much inside, you have to pull it out. And then you have to see whether you have to say whether you have put NIV-NAVA or you have to put or you have invasive NAVA, what NAVA number you have kept, what PEEP you have to keep, what pressure you are keeping above PEEP, and what is the backup pressure and rates and inspiratory time you are keeping, what is the alarm you are setting, apnea time, what alarm you are setting, and what alarm you are setting for the peak pressures. And depending on the baby, you will do the blood gases, and call for increased work of breathing, increased FiO2, frequent desaturation or bradycardia. So then you need to change the settings. So this is how the proper EDI catheter would look like. Maximum ECG here, smallest here with no P wave, and blue in the center, which is fine. And this fine would, this is on the baby, which we had used, and this is how it looks like. Quite synchronous waves of the EDI and the pressure, flow, and the volume. So this is how it looks like. How do you wean the NAVA? So you will wean the NAVA when you have reached lower pressure with the tidal volume, which is coming normal, and with the lower EDI and with the lower NAVA level. That's the time when you are going to wean the NAVA. So what does it mean? That if it is usually PIP and the respiratory rate is decided by the patient. So only thing what you can reduce is NAVA. So when do you reduce? When your EDI and PIP has reduced while the tidal volume remains the same. So you see your EDI has reduced, your PIP has reduced, but your tidal volume is good. So this is the time when you can start reducing your NAVA. So this is important, that you have decreased, you have come down on your EDI and PIP, but your tidal volume is fine. That means this is a time when you can wean the NAVA, and you start weaning the NAVA by steps of 0.5, and keep a watch on the PIP, what is happening to the PIP. As the NAVA level is reduced also, now work of breathing, instead of the ventilator, baby is the one who is going to do the work of breathing. So when do you extubate a baby from here? When you are reached a very low PIP and a low NAVA level. So the clinical tips would be, we should know that EDI signal in the newborn is variable. There can be a significant breath-to-breath variability in the peak pressures and the respiratory rate. So you should not just see one thing, but you should see the trend of the monitor over a period of time, not just one breath-to-breath response, see and change. Don't do that. Give some time. And during the placement of EDI catheter, the most important is the progression of the EKG signals. And as I said, the largest P waves and the QRS complex is in the upper lead. The lowest is having no P waves and a very small QRS complex is the lowest lead. And the color is blue in between. If the EKG progression is appropriate, the color drift does not seem to have an impact on effectiveness of NAVA. So this is how it would look like. Maximum, lowest, and the blue lines in between. So the starting of the NAVA level can vary because the neonate will adjust the EDI signal. That's why I said give some time, because newborn will adjust the EDI signal to deliver the required pressure. And if the EDI is persistently high, increase the NAVA level so as to unload the neonate, because now baby is trying to actually produce more, doing more work by generating more contractions so as to build up more pressure. So you have to unload the neonate and allow the ventilator to do more work of breathing. So increase the NAVA level. And if the EDI peak is consistently low, that means the baby doesn't require it. So decrease the NAVA level so as to now allow ventilator to contribute less and baby to contribute more in the work of breathing. And you should adjust the NAVA level at increment of 0.1 to 0.2. The another is about the apnea alarm, because this is important, because if you are keeping an apnea alarm at 20 seconds, the backup ventilation will not start until 20 seconds have passed. And some babies may become hemodynamically quite unstable till that time. Delay has happened for the backup ventilation. So, so if you keep the alarm setup as low as 5 seconds, the baby would be clinically more stable. So supposing if you have kept the 15 seconds, then the minimum rate would be 4 breaths per minute. So I don't think so 4 breaths per minute is good enough. 10 seconds is 6 breaths per minute, and 5 seconds is 12 breaths per minute. So, and the 4 second is 15, 3 is 20, and 2 second is 30. So 20 and 30 is quite high for the apnea setup to be done, but at least this 5 second is a good apnea alarm number, where the minimum rate is 12 breaths per minute. And so when the baby is not breathing even 12 breaths per minute, that is the time when the backup thing would start. Another clinical tip is that most of the patient's failure is due to apnea. And this may happen if you're giving a sedation, analgesia, which may suppress the respiratory drive. And this is the main factor to have a NAVA failure in the babies. And another thing is that if we have a premature baby and we are using NAVA without caffeine, there is a high chance of failure of the NAVA. And hence, whenever you start a baby on a NAVA, we should give baby, we should load the baby with the caffeine. And sometimes when the baby has apnea, you may, and we all know that the smaller baby may require a higher dose of caffeine sometimes. So we give a 20 milligram per kg of a loading dose, and then we start with the 5 mg per kg of maintenance dose. But some of the babies may require more than that, 10 to 15 mg per kg as a maintenance dose. So, so it is NAVA is a synchronous non-invasive ventilation which compensates for leak. And this is how the NAVA setup would look like, that there will be a NAVA level, there will be PEEP, and there will be FiO2, and there is a trigger, and this will be a backup PIP and the rate and the inspiratory time. So you set up that and then you accept it. So in conclusion, the neonates appear to have intact neuroventilatory coupling with functional feedback pathways. And it's very important for which patient you would need to select, because all babies would not be candidate for NAVA. And some may not be candidate all the time, because in some situation, this baby may need NAVA. And especially we've seen the babies on BPD, they have whom you are not able to wean, or the babies who are fighting and asynchronous, those babies are really very happy with NAVA. And many neonates ventilate on NAVA with the lower PIP and FiO2 than when they are being ventilated on conventional ventilation, which we saw those examples, the PIP had come down. And with those lower pressures itself, the blood gases are improving. And many of these babies decrease their own PIP and tidal volume over time while on NAVA. This is auto weaning, because their EDI will start improving. And many neonates have improved compliance on NAVA. This can be also used along with the Surventa or Curosuf or nitric oxide, or if you have pneumothorax. So this can be used with those kind of babies. In this small number of patients, no significant complication or side effects were noted while on NAVA when you are giving these modalities. But this is all biological plausibility, and always we have seen that there is a biological plausibility, and then we start doing some intervention, and then we need to look at whether really that biological plausibility work in our babies or it doesn't work in our babies. So for that, how do we know until unless we have evidence? So you need to have a large multicentric trials to answer questions if NAVA decreases time on ventilator, if NAVA decreases the incidence of chronic lung disease, or if NAVA really improves the outcome before you hop and go to the new ventilator mode. And also I would suggest that don't jump into even CPAP, even NIPPV, don't jump until unless you have done a proper hands-on training on that before you go. So the NAVA is a mode of mechanical ventilation in which positive pressure is applied in proportion to electrical activation of diaphragm. And as the EDI progressively increases, the assist increases proportionately, and the pressure delivered to the ventilator is cycled off when EDI is entered by the respiratory center. And amount of assist NAVA level, which defines the magnitude of pressure delivered for a given EDI. So this is what NAVA does in brief. Let's look at few of the studies which we have. So in 2008, the study had come on rabbits, where they found that they were able to deliver this non-invasive way to the rabbits. And in 2007, it was seen that they were able to cycle on and off during maximal inspiratory efforts in humans. And another study on the rabbits showed that the diaphragm unload was better than the pressure support ventilation with NAVA. And again, in the rabbits, it was seen that unload effort in the lung injury without increasing the tidal volume was happening, and less over assistance and better PT ventilation synchrony was happening. So these were small studies on the animals. And then on human beings, when the studies were done by NAVA to look at the patient ventilator asynchrony during the support ventilation as compared to the neurally adjusted ventilator in infants and children. So this was studied in 2013, and it was a prospective randomized crossover study. So they had put a baby on one mode and then put on the another mode. And only 6 subjects were taken, 4 weeks to 5 years was the age. And they looked at the difference, and they found that if we compared with pressure support, NIV-NAVA improved the patient ventilator synchrony by reducing the trigger delay and the number of asynchrony events. So this was very small crossover trial. And then there was another study which compared work of breathing between non-invasive ventilation and neurally adjusted ventilator assist in healthy and lung injured piglet model. And they found that it did decrease in work of breathing. Then on a preterm baby, there was a study by Yonara et al. And they compared non-invasive NAVA with the nasal intermittent positive pressure ventilation, NIPPV. And it was a retrospective study of less than 30 weeks of gestation. And they were also very small number. 15 babies were in NIV-NAVA and 19 babies were on NIPPV. And the babies who were on NIV-NAVA were smaller in gestation than the babies who were in NIPPV. But in spite of the fact that they were a smaller gestational baby, the extubation success was better, more than 7 days, and was equal between NIV-NAVA and NIPPV, around 60% and 53%. So extubation success rate was almost similar. And then there was another study, which was a randomized phase 2 crossover trial, which showed that the NAVA had, NIV-NAVA had a lesser trigger delay, had a lesser requirement of the peak inspiratory pressure, lesser time they were babies on asynchrony, and asynchrony index was much lesser as compared to those who were on NIV pressure support. And these were quite small babies, 27 weeks and 25 days old. So the feasibility and physiological effects of NIV-NAVA in the crossover trial was quite good. And these were 25 weeks baby, and it did show that it is actually the time when the baby is in the saturation proper mode is much better, and frequency of desaturation, length of desaturation, and phasic EDI, infant movement, caretaker movements were better than NIPPV. Another study, prospective randomized crossover physiological study in PICU, where they actually compared NIV-NAVA versus PSV. So it was a physiological study on 18 children who had acute respiratory failure needing non-invasive ventilation. They found that NIV-NAVA had a reduced asynchrony index, had improved neuroventilatory coupling, reduced peak and mean airway pressure, and improved oxygenation index. And there were no adverse events reported. So in the neonates, these were the studies on the bigger children. So in the neonates, it does make a big difference. Again, I said it would need a very large multicentric trial before we actually start giving to all our babies. Thank you. Open for questions.
Thank you, Dr. Monika, for taking us through a very complex and novel kind of ventilatory or respiratory support mode, that is NAVA. You have really elaborately covered from the basics, the physiological effects, to the clinical effects, and then certain technical issues. Now, for all of us, it was quite enlightening to listen to this elaborate talk, because as you know, and as you have elaborated, it is not being extensively used. And as we learn about it from the people who are using, like you and others, we will start to think about implementing and using it in our units. As far as questions are concerned, There are one or two questions. One of the questions participant has asked is, does every baby who is to be put on NAVA require continuous ECG monitoring using a separate ECG machine?
Yes, I mean, this one is just to see where your catheter has gone. Is it in a right position or not? But to see the ECG, you need a ECG monitor, like what you are using, the normal, your multi-channel monitor. You need to put that.
But it's not mandatory or necessary just for the sake of NAVA, isn't it?
No. It's not for
Because
the NAVA. It is for the
this-
baby. If you want to
Yeah.
see the,
So-
it's for that, not for the NAVA.
Yeah, technically, as you have elaborated in your talk, that this
Yeah.
retrograde EKG or ECG
Yeah.
is there once you put in that catheter, ED catheter, it will pick up the signals and that will help in
Yeah,
positioning the catheter.
So, I mean, if you
So that
want
is
to
the
really
purpose.
use, yeah, that's what I want to say. If you want to know the, for the hemodynamic purpose, you need to have.
Yeah, right. The second question is NAVA a primary modality for ventilation or it is a switchover modality?
See, some of the units who are like, it comes like, what is your unit experience? So like if you not only NAVA, like even if you look at a high frequency ventilation or we will be coming to a non-invasive high frequency ventilation. So some of the units who have the experience and they are putting as a primary mode, these kind of ventilation modalities. But for us, and as far as the evidence is there, we are not putting the babies on as a primary mode of ventilation, and only we are putting as a switchover. But some of the units are using this as a primary mode of ventilation in Netherlands, and some of the units in the US as well, where it's being used as a primary mode. And one of the unit in UAE also, they are using it as a primary mode, but most of us are not using it as a primary mode. We are using it as a switchover.
Okay. So what is your personal experience of using NAVA in NICU or new
So
NAVA?
we had used it in the babies with BPDs and those babies who are who were really fighting on the ventilator, who were not maintaining their CO2s, who were very long time on the ventilator. These are the babies we were actually putting the baby on NAVA.
Not as a
And
primary
we had a good
support.
experience. We had a good experience in these babies.
Not as a primary support.
We never used it as a primary support.
Okay.
No, we didn't use it.
Yeah. And what is your observation when you put the babies on NAVA as far as the personnel who are concerned, who are taking care, like the nursing staff or the healthcare workers? Do they require training,
No,
number
first of
one?
all,
And
see,
number
whenever you
two,
use,
sorry,
yeah,
do they
see, what
require
you are saying
training?
is right. Yeah, this is very important. They all require training, and because it was a new thing for everybody, so the nurses required and the registrars and even me, we required a frequent training, and we had sent few of them to the unit which were using NAVA very frequently to see how exactly, because saying something is different from doing things. So
Yeah.
to see when the babies are put, how do they behave, what are exactly is to be seen, and how to titrate. So we had done personal training by the person who, of course, the biomed person, plus we had sent to the units which were using the NAVA.
Yeah, right. And that is very
Never
important.
do
That
anything without training.
yeah, and that is very important in a modality
Yeah.
like NAVA, because if you see the terminologies which are used in NAVA, they are unlike the ventilator terminology.
Yeah.
You will have to learn, relearn, and again learn, and importantly take a hands-on training before you think of introducing in your unit. It's very important. So the next question is why there are no studies concerning long-term outcomes of NAVA?
No, because we don't have much studies. So long-term outcomes will come when we have proper randomized controlled trials of NAVA, and then we will be looking at taking those babies and seeing the long-term. So they are going on. It's not that it's not going on. So the units which are doing this, they are, and some studies are going, will come.
Yeah, right. There are very few studies which are going on when the results are awaited. But if you see at the studies which were done previously, most of the comparisons were done with the CPAP, nasal CPAP. And now
Yeah.
there is some shift to the use of NIPPV as a primary modality of support. So those trials are undergoing. So you are right. We'll have to wait for those trial results, and then we will go for the long-term outcomes. Yeah, right. The next question is, can PEEP titration and lung recruitment be done with NAVA using minimum editing? I do not understand. What is that mean editing? Or
No,
ED
he's saying
mean?
medium,
ED mean you must be meaning it.
EDI.
Can PEEP titration and lung recruitment be done with NAVA?
Yeah, PEEP titration can be done because we have to look at, as I said, minimum EDI you have to see. If your minimum EDI is very high, then you have to titrate the PEEP down. If your minimum EDI is too low, then you have to increase your PEEP. So that is how you will go for the PEEP titration depending on your minimum EDI. So that part can be done, but lung recruitment, as you what do they mean by lung recruitment? Means you want to like sustain inflation or something, or going higher than coming down. That's not done. The only thing what is done is to have an optimal PEEP looking at the EDI levels, minimum EDI levels.
Okay. Next question is, in a neuroparalyzed baby, very few babies are neuroparalyzed. Does the NAVA catheter register ED from brainstem till diaphragm?
The neuroparalyzed babies, I don't think so you can do NAVA, because if you're paralyzed, it will also be paralyzing the diaphragm, and you're looking at the diaphragm electrical activity. So do that.
Yeah.
Even
Like
too much of sedation, if you have given, it will be a problem.
right. If there is an unpredictable drive because of some reason, those babies are not to be put on NAVA.
Yeah.
So is NAVA also helpful in cases of diaphragmatic hernia?
So my experience is not there on that, but we had experience by our the unit which is doing a lot of NAVA. They had used in diaphragmatic hernia baby, and but we don't have too much of information on diaphragmatic hernia and NAVA. But that unit had done, and they said it worked.
Right. Next question is, what about sedation and paralysis used in ARDS in PQ patients? Is it helpful in these patients?
No, I mean, as I said, we cannot paralyze the patient for NAVA. If you have paralyzed the patient, you cannot use NAVA. And sedation also, heavy sedation, you cannot use for using the NAVA. And for in that matter, even if you want to use a NIPPV, you cannot use a lot of sedation. And the first indication for putting a baby on non-invasive mode is that baby should have his own respiratory drive. If that's not there, then you cannot put the babies on those non-invasive modes.
Just a question, ma'am. In which babies are to be put on non-invasive NAVA and which babies are to be put on invasive NAVA?
Usually, if you see that baby who is like how we take a call on invasive ventilation and on non-invasive ventilation, the same criteria would be here. Like if we know that our baby's lungs are pretty bad, and those babies you will have to put on invasive ventilation only. Those babies now already now we know that if it is a preterm baby who has received, whose mom has been given steroid, whom you have given proper support during the delivery room, and you have given surfactant quite early, and you know that the baby has a good respiratory drive and is not that bad, you will put on NAVA. Or if the baby is very sick and has a very bad respiratory distress and is hemodynamically quite unstable, you cannot put that baby on NAVA.
Thank you.
Yeah. The next question is there a leak compensation in new NAVA?
Yeah.
And how is it?
It's because it's not taking the stimulation, or the trigger is not your flow. So there is no question of the leak issues coming, and that is the biggest actually beauty of this NAVA, that you don't depend on that. And so because it is looking at the electrical activity of the diaphragm, that is a trick.
Yeah, it is not looking at the flow or leaks. What is the cost, approximate cost of the NAVA calculator? It must be variable, but what is it in your?
Even in my place, if you ask me cost of things, I really don't know. If I will build my own hospital, then I will know the cost.
No, the Akashi is using it. Maybe he can tell about the cost.
Unless and until, as ma'am has said, sir, unless and until we have our own units.
Yeah, as long as
we just say bring this, get this, get this.
Yeah, you are right. So
I'm sorry.
Questions are, most of the questions are over. Thank you once again, Monika, for this elaborate talk. Very difficult to make it understand, particularly for the novices. And I think definitely it is an exciting to look at this modality and to take it forward in clinical use, because the basic concept of this NAVA is to make the ventilator breathe like baby rather than baby breathing like the ventilator. So that is the beauty of this NAVA concept. And I'm very sure that increasingly people will start to use this NAVA. So thank you once again, Monika, and I hand it over to Dr. Akash to conclude.
Thank you so much, ma'am, for first understanding it so well and then making us understand it so well. It was mesmerizing, and you have covered it through and through. I think if we had a baby with the worst possible lungs, we could have managed that baby well with this modality. The way you explained it and the pictures and the diagrams were excellent. And thank you so much, sir, for moderating this session. And despite spending almost more than 1.5 hours, we still are very much into this lecture, and we all did not went into apnea, and we were all active. That is the beauty of the lecture.
Yeah.
Thank you so much, ma'am. We all loved it.
Yeah.
Thank you.
Thank you. Okay. Good night.
Bye-bye.
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 And thank you all for attending.
Thank you, everybody.